we are going to have a very severe access challenge that's going to continue to become worse if we don't address the need for clinically appropriate access to care.
Welcome to Off the Chart with Medical Economics, a podcast featuring lively and informative conversations with healthcare experts, opinion leaders, and practicing physicians about the challenges facing doctors and medical practices. I'm your host, Keith Reynolds, and today we feature a conversation between Medical Economics Editorial Director Chris Mazzolini and Dr. Evie Cunningham, Chief of Virtual Health and Digital Care at Providence, founder of MedPearl, and an OBGYN. Today, they'll be talking about challenges with patient management and workflow.
Dr. Evie Cunningham, thanks so much for joining me today. I really appreciate it.
Thanks for having me. Excited to be here.
So today we're going to be chatting about some of the common, patient management and workflow challenges that doctors deal with, and some ways that Dr. Cunningham and her team is working to address them. So the first question I have for you is, around, sort of thorny areas like evaluation and management, referral decisions. Why are these things so challenging and time consuming for primary care physicians?
Yeah, the world today is very different from the world when I went to medical school. Medical knowledge doubles every 3 months. When I went to medical school, it was every 20 years. And medical knowledge does not live in the electronic health record. The electronic health record isn't clinically intelligent, okay? And then the average patient chart has anywhere from 50,000 to 200,000 data points. So it's almost impossible for clinicians. It's impossible for us to consume all the information that we need to know and all the information that's in a patient's chart to really inform the best decision-making. So this feeling of overwhelm, it's more severe and more significant with primary care. And the reason why is because I'm an OBGYN physician. When I go into a patient's chart, I only have to look up the things that are relevant to the gynecology patient that's in front of me. So if they had a knee surgery last year, that's interesting, but it's not something that I'm typically going to do very much with from a clinical perspective. So the chart biopsy that I perform is much narrower than somebody like primary care who they feel responsible for all of it. And when we talk about the referral dysfunction, the issue that we have here is that it's estimated that about 50% of the time when a patient gets referred from primary care to specialty care, there's probably some opportunities to improve or optimize that transition. And it's usually clinically related things. So for example, patient gets sent to the wrong specialist. This just happened to me a couple weeks ago where I saw a patient who got referred to me, had waited 4 months to see me, and she really needed to see endocrine because she had an endocrinology problem. So saw me, I said, I can't fix your problem. You have to go to endocrine, another 3 months to see that. That happens all the time. You talk to doctors, they say, oh yeah, that happens all the time. The other thing that happens, patient gets referred to the headache specialist, let's give an example, because they have chronic headaches and it's sort of, the primary care sees a lot of patients with these headaches. They're really complex, to kind of distill down to what to do and optimize the plan. And the patient waits for 5 months, which is the wait time that we have here, to be seen. And the primary care clinician could have done 2 or 3 things medication-wise, been empowered to do that, and maybe ordered an imaging study if it was appropriate on the way to see the headache specialist, but they don't always have the right information in front of them at the point of care to do that because they can't consume everything. They can't know everything that they need to know. It's just not humanly possible. And that happens quite a bit where the patients get sent to the specialist and they don't have an optimized, what we call workup. Multiple things that you could do on the way to see the specialist. And then the third thing that happens is there's a lot of patients we see that don't need to see the specialist at all, right? And so the problem that we have today now is that we have a shortage of doctors. We have 10 10,000 patients aging into Medicare every day. And we have a massive amount of burnout and a lot of primary care clinicians leaving just because it's just not sustainable. And so we are going to have a very severe access challenge that's going to continue to become worse if we don't address the need for clinically appropriate access to care. It's not just about access to care. It's about making sure that patients, the most clinically appropriate patients, get to the right type of clinician with the right pre-visit workup and at the right level of urgency. And if you can solve that problem, think about how much access we can open up to care by making every visit count. So that's the problem that we're trying to solve with the solution that we're building.
Say, Keith, this is all well and good, but what if someone is looking for more clinical information?
Oh, then they want to check out our sister site, patientcareonline.com, the leading clinical resource for primary care physicians. Again, that's patientcareonline.com.
MedPearl is the solution that you guys are working on to try to address some of these obviously thorny issues that all doctors are dealing with. So can you talk a little bit about MedPearl and, how it came about, what it's aiming to address, and, just sort of the story of that a bit?
Yeah, so I was working as a chief medical officer of a medical group, and I've been a physician leader for years where I've led physician groups, and this problem with referrals was like something I would hear all the time. Primary care complains, they say, I don't know what the specialists want me to do, or the specialist rejects my patient, or this patient gets frustrated because they can't get in time, and then they leave the system to go to a place to get sooner. And I'm so frustrated. And then you talk to the specialist, and the specialists say, primary care doesn't know how to send me the right patients. I'm a surgeon. Why are they sending me medical back pain, for example, when they should be going to PT? And so when you talk to the specialist and you talk to the primary care, there's a knowledge sharing gap that we have across our community. It used to be we would go to the doctor's lounge and we'd sit down and we'd, chat with each other and talk about each other's patients and collaborate that way. That was like the old days. Now we live a lot in digital silos. And so we're not always accessible to each other. We're not always communicating with each other. And patients are more and more complex, and there are more and more administrative things to do. So what I thought was, when I looked around, I would hear this from my peers, right? My colleagues, and everybody kind of knew this problem existed. There wasn't really a great technology solution out there. And the way we were trying to solve it was like sticky notes and PDF files and SharePoints and little algorithm sheets and things like that of like, when you refer to endocrine for a thyroid nodule, do this, then do that. And so all this stuff is floating around, and it's completely unsustainable for primary care. It's not their fault. That's the other thing I want to point out. Primary care clinicians are amazing and wonderful humans, and we've got to create technology for them so that they feel supported. So what we did was we went to primary care, we went to the clinicians, and we got some engineers together and we said, you understand this problem. Tell us, how do you want this information delivered to you? How do you want it organized? What are the rocks that you have in your shoes? How should we design the solution around you? And that's really the genesis of how MedPearl was designed. It was designed in a very clinician-centric way. And we designed this platform where we can create, collaborate, govern, maintain, and develop digitally consumable clinical content that can be delivered to the point of care in a back-end clinical intelligence hub where all of the content and all of the information that we share with each other is done, it's built by clinicians, for clinicians in a no-code environment. And that was one of the missing pieces, is that we were always, we had these Visio charts or diagrams, and we would have to give them to somebody, and then an engineer would have to load it into something. And then when you had to make a change, it would take, you didn't have the ability or empowerment as clinicians to change things. So we have topics in our platform right now they're changing every week, like COVID, and so we can't depend on manual, making changes on something that then goes into another system that then goes to this, that then gets changed. We need to be able to update things rapidly and be empowered to do that. So that's what we've done. And then the platform itself, it delivers the information from within the electronic health record. So the clinicians can launch within the electronic health record, and then it's context aware to the patient that you're seeing, and it gives next best actions and guidance around almost 900 referral guides and topics and algorithms. Constitutes about 95% of what a PCP or primary care clinician sees. And then it also digs out the relevant patient data in the context of the particular condition that you're looking at. So it reduces cognitive burden, it speeds up clinical decision-making, it eases the way for patients, it improves patient experience because it's improving that transition experience. And we're sharing knowledge, we're democratizing that expertise in a more meaningful way across our community.
So MedPearl came to my attention because I saw a case study in, I think it was the August issue of New England Journal of Medicine Catalyst. Can you tell me a bit about that case study, what you looked at, what you found, your conclusions, and that sort of thing?
Yeah, I mean, it really tells the story of the genesis of the product and and the different things that we went through. But yeah, I mean, one of the things that's, I think, really tough with a lot of these digital health products is that they don't always have evidence-based research or really good analytics or data or outcomes to really demonstrate, like, what is the value that you're bringing by bringing this solution in? And so we wanted to take a very data-driven approach to showing the impact that we were able to make. So we started with a pilot in 2022 with 200 plus clinicians, and we were able to demonstrate with that clinician group when they searched MedPearl, 20% of the time they didn't need to refer the patient at all. About 72% of the time, it helped them remind them to do something in the workup or order a lab or order a test or start the patient on a medication that they would not otherwise have done. And 20% of the time, they changed the specialty or the level of urgency. So that case that I was telling you about, patient should have gone to endocrine, that would have been solved if that primary care clinician who referred that patient to me had actually had MedPearl at their fingertips, because it would have directed them to do a different path for the patient. And so those are really great metrics and signals for an initial pilot to show, like, if we're making this much of an impact, think about the impact that we're making on clinically appropriate access, optimizing patients. So then we scaled the product across Providence in 2023. We started the scaling process, and that was great. We've now gotten to a place where we have over 7,000 clinician users. We did the EMR integration piece last year in September. So it's been about a year on that journey. And that really even accelerated the adoption and the use. We've been able to demonstrate improved productivity for our super users. So clinicians who are using it are more productive, but we're not asking them to see more patients. So that really shows that we're elevating them to a higher level of licensure. We've been able to demonstrate improved referral value. That's actually something that's really important in a health system. You look at the value of the referrals and say, what is the downstream consequences of these referrals? Are these patients that are getting referred for back pain converting to surgery, or are they going to PT? And are the ones that are converting to surgery more appropriately going to the spine surgeon versus the ones that aren't surgical going to the PT? You want to make sure you make those delineations. And so you want your specialists to be seeing the highest acuity things that they should be seeing. And you want your advanced practice or your allied health professionals to be seeing the things that are more appropriate for non-specialist care. And so that's kind of the holy grail. If you can create a mechanism to be able to do that, and it's a very clinical problem. So that's some of the metrics. We've also been able to demonstrate improved EHR efficiency scores and reduced pajama time for our clinicians for after hours. So those are things that dig into the burnout factor. And then we also did in our pilot, I forgot to mention this, we did a pre and post survey on our pilot participants to say, what is your level of competence and confidence with doing referrals, working up referrals, sending referrals to the right way, with MedPearl, pre-MedPearl and post-MedPearl. And there's a statistically significant improvement in confidence level as well, which is important because, again, it digs into that factor around feeling empowered, upskilling or onboarding folks more quickly. We know there's going to be a lot of advanced practice clinicians going into primary care, supporting the primary care access issues. We need to make them feel empowered as much as possible. So this technology really takes the wisdom from the specialist brain and codifies it into this platform and delivers it to them in a useful and meaningful way.
Oh, you say you're a practice leader or administrator? We've got just the thing. Our sister site, physicianspractice.com, your one-stop shop for all the expert tips and tricks that will get your practice really humming. Again, that's physicianspractice.com.
So, you had mentioned earlier on that, a lot of this was built with, sort of real world knowledge and experience of the providers, the physicians that are on the ground. Why is it so important to have, the actual clinicians be involved in, making sure a solution, actually works in the real world?
Yeah, I think that's kind of where digital health missed out on the last decade, to be completely honest. I think a lot of money was spent on building a lot of things that didn't get adopted and didn't get used. And it was all well intended. There were a lot of people who wanted to see if they could help fix healthcare. They saw it as right for disruption. It's very difficult to disrupt healthcare because of just it's different. It's different from the movie business. We're not Blockbuster. We're much more complicated than that. And so there just are so many factors and intricacies involved, and a lot of the control still remains with the people who deliver the care themselves, just from a regulatory licensing perspective. So I really do think, and when you look and see some of the technologies that are really starting to launch and get a lot of interest and buzz, I really do see clinical integration with those technology teams and that co-development process as probably being one of the most critical factors of the success. You have to understand how the work is done. You have to understand the workflow, the change management process, the psychology. I think one of the reasons we've been successful partially is just because I was a medical group leader. I had a lot of relationships. I had influence. I had a great network. So we were able to kind of get that process started and get buy-in for it. And then once the clinicians buy into it, they sell it to each other, right? So it's not hard. We're not even, we get inbounds all the time from health systems wanting to get a demo. That New England Journal article, for example, a bunch of health systems reached out. They're interested because they understand the problem resonates with them, and they know there's not a lot of great solutions out there on the market that address it in this way, or you have to do a very customized, high maintenance build internally in your system if you want to address something similar, and it's not really designed for that. So that's why I really do think it's very important for clinicians to be involved in the evaluation and assessment of these different products and solutions that are out there, especially if they're affecting clinical care directly. Yeah.
Last question, what's next for MedPearl?
Well, we are working on implementations in a couple other health systems. So that's really exciting. We want to bring this supportive technology to the world. We want to share it with the world because it has brought a lot of joy and delight to our clinicians at Providence. And that is an extension of Providence's mission, is to meet the needs of all communities, in especially poor and vulnerable communities. I would say one of the biggest areas of opportunity that I think MedPearl has is meeting patients in underserved areas and rural areas, especially rural areas where you have clinicians who are out completely on their own. It's 4 to 5 hour drive sometimes for a patient to get in to see a specialist. How do you empower that physician assistant or family medicine doc that's out in a more rural area to be able to maximize what they can do for their patients? And so we are one of the health systems we're launching in two of them, are rural health systems, and one is a tribal health authority as well. So it's really exciting for me to see that we are going to democratize knowledge and bring it into all these different communities and continue to extend the mission of Providence through this great technology.
Dr. Evie Cunningham, thank you so much for joining me today and sharing your insights. I really appreciate it.
Yeah, thank you.
Again, that was Medical Economics Editorial Director Chris Mazzolini and Dr. Evie Cunningham, Chief of Virtual Health and Digital Care at Providence, as well as the founder of MedPearl. My name is Keith Reynolds, and on behalf of the whole Medical Economics team, I'd like to thank you for listening and ask that you please subscribe to the show on Apple Podcasts and Spotify. Also, if you'd like a digest of the best stories Medical Economics publishes delivered straight to your email 6 days a week, subscribe to our newsletter at medicaleconomics.com. Medical Economics, Patient Care Online, and Physicians Practice are all members of the MJH Life Sciences family. Thank you.